Our next speaker is a man who refers to himself as the Rick Moranis of adult congenital heart disease. On a serious note, Jamil's brought our program both inside the cath lab and outside the cath lab to new levels. He's a great coworker, a fantastic doctor. We learn so much from him every day. But behind every great man is a great woman. I'm not talking about his wife, but I also wanted to acknowledge Pam and Linda and everybody who put together this program. Jamil had a lot to do with it. But there's a lot he doesn't do as well.
Thank you for that introduction. I just want to echo that. This meeting is really the product of so many people working together to make it happen, and I think Pam and Linda, but especially Pam for this particular meeting has really done pretty much most of the work. So I am going to talk about transcatheter valve replacement in the adult congenital population, and we're really going to focus on the Melody valve, which is the one that we've been using widely at this point, but I'll touch briefly on some other applications. So no disclosures for this, no conflict of interest, but I would like some. Where's Frank? Background, we've already established that most children with congenital heart disease are now surviving to reach adulthood, and I'm really going to focus on tetralogy of Fallot today. Because nowhere is this success more evident than in those with tetralogy of Fallot and other forms of right ventricular outflow tract obstruction. Tetralogy of Fallot is the most commonly encountered cyanotic congenital heart disease, and most adult patients in the United States have already been repaired. It's a heterogeneous population as far as the repairs go. Less than 20% are unrepaired or palliated. They have shunts like the Blalock-Taussig shunt, the Potts shunt, the Waterston shunt, but repaired TOF patients are in themselves, those that have actually had valve replacement and VSD closure, are in themselves a pretty heterogeneous population. So in looking at our repaired adult tetralogy patients at UCLA, and this was a couple of years ago where we looked at 328 patients at our center, and we found that about 26% had either trans or subannular patches. 41% had some form of bioprosthetic valve that had been placed, and 33% had conduits, and the vast majority are homografts, either aortic or pulmonary homografts. What are the issues to consider? Patients with a transannular patch almost invariably have severe pulmonary regurgitation. Please look for this in your practice and suspect any reports that say only mild PR. And I see a lot of adult cardiology practice send us patients who have transannular patches and just says there's mild PR. So looking for pulmonary regurgitation is very important. Conduits and bioprosthetic valves often have a mix of PS and PR. We spent an entire session yesterday afternoon discussing various arrhythmias, ventricular and supraventricular arrhythmias, and about 30% of patients with repaired tetralogy of Fallot have either a history of VT or SVT. And these are associated with hemodynamic abnormalities of PS and PR. So it's not just functional deterioration, it's also electrical deterioration and a higher risk of sudden death. It's important to keep in mind that RV and LV systolic function may be abnormal. Diastolic dysfunction of the left ventricle is also very important as a predictor of ventricular tachycardia. Keep in mind aortic root and aortic valve problems and the presence of residual VSDs that may need to be addressed at the time of valve replacement. We must know how to look for pulmonary regurgitation. MRI with velocity encoding, Dr. Ranella yesterday gave a very nice talk about this, is currently thought of as the clinical gold standard for determining severity of pulmonary regurgitation, and a cutoff of greater or equal to the 40% regurgitant fraction is considered severe PR, but really anything above 32% is fair game as far as considering it at least moderately severe PR. 2D, echo, and Doppler can also be used to accurately identify patients with severe pulmonary regurgitation. This is from a manuscript a couple of years ago that Dr. Ranella and I and some other folks here worked on, where we took a series of patients who had various forms of RVOT dysfunction, and they had MRIs, and we looked at which echocardiographic variables could be used to identify those with severe pulmonary regurgitation. Mostly MRI is great, but MRI is expensive. If you have Medi-Cal, you cannot get an MRI, cardiac MRI these days. And so, we need low-cost ways of identifying these patients. So we found that there are various measures that identify severe PR, but really if you had to take one that has the highest sensitivity, specificity, positive and negative predictive value, it's flow reversal in the branch pulmonary artery. So for those that are echocardiographers or ultrasonographers in the audience, if you have a patient with tetralogy of Fallot, please focus on the branch pulmonary arteries in the short axis view or a suprasternal notch view, really any view where you can see the branch pulmonary arteries. Turn down the Nyquist limit so you can see branch PA flow reversal, and you can do pulse wave Doppler in those branch PAs. We found an 87% sensitivity and specificity when we use that. There are various other indices that can be used, like pressure half-time of the PR jet. A short pressure half-time, less than 100 milliseconds, suggests severe pulmonary regurgitation, but that can also be because you have a very stiff and non-compliant right ventricle, so it doesn't necessarily identify the PR regurgitant fraction. And then there's something called the PR index, which is essentially a measure of the duration of pulmonary regurgitation over the duration of diastole. So the shorter your pulmonary regurgitation lasts, the more severe your PR is, or the less compliant your ventricle is. We came up with this. This is a CART analysis, and it's essentially an algorithm that can be used, and it's very easy to use. You just ask yourself two questions when you're looking at an echo. One is there branch PA diastolic flow reversal? If the answer is yes, then you go to the next question. You say, is the PR index less than 0.77? Does pulmonary regurgitation last less than 77% of diastole? And if that's the case, then the answer is yes, then 100% of those patients had severe PR identified by cardiac MRI. If the answer is no to both of those questions, then 0% had severe PR. This is not a hit on cardiac surgery, but this is a study that we did a couple of years ago, a multi-center study, where we looked at the prevalence of various arrhythmias, atrial and ventricular arrhythmias. Dr. Moore quoted this paper yesterday in repaired adults with congenital heart, with tetralogy of Fallot, and we found that the number of cardiac surgeries that the patients go through really increase the prevalence of these arrhythmias. If you've had more than 5 or equal to or more than 5 cardiac surgeries, the risk of that patient having ventricular tachycardia or ventricular fibrillation is 35%. A little bit higher for atrial arrhythmias. And so this is one of the reasons that it's important to have alternatives when it comes to replacing dysfunctional homografts and dysfunctional bioprosthetic valves. I'm really hesitant to put people through 5, 6, 7 surgeries in a lifetime if we have other choices. And now we do, thanks to Philippe Bonhoeffer and Great Ormond Street. And this is from the Lancet. I believe this is in 2000 or 2001, the first description of percutaneous pulmonary valve replacement or percutaneous replacement period. I remember when I was a fellow back in 2002 and I attended an ACC meeting, and in one session you had Philippe Bonhoeffer describing his initial experience, and he was followed by Alain Cribier describing his initial experience with what later became the Edwards sapien valve. And this guy had put in, Bonhoeffer had put in 3, Cribier had put in 1, and so 10 years later the field has really just rocketed upwards. Percutaneous pulmonary valve replacement is really changing the practice of adult congenital heart disease, and specifically the treatment of tetralogy of Fallot. We now have an FDA-approved and HDE approval of this Melody valve for RV to PA conduits that have greater than or equal to moderate pulmonary regurgitation or pulmonary stenosis, and I'll go through some of these indications. The size is the problem. This is the Achilles heel we're facing now, is that the Melody valve goes up to 22 millimeters, and so If you have a larger conduit or bioprosthetic valve than that, or if you have a native RVOT that's larger than that, we just cannot treat this with this particular valve. Now, the Edwards Sapien valve that Dr. Tobis has been using for the transcatheter aortic valve replacements, I think is going to expand our horizons and allow us to put these valves into larger conduits. Although the FDA approval is for these valves to be used in conduits, they're actually the easiest place to put them and the most effective place is actually in bioprosthetic valves, dysfunctional bioprosthetic valves. And if you looked at our numbers in our adult population, I believe we had about 40% of our patients had bioprosthetic valves. So we've been applying it widely in bioprosthetic valves. These are the entry criteria for the US IDE trial for the Melody valve. So you can't have children that are younger than 5 years of age. They have to weigh more than 30 kilos. They have to have an original conduit that's larger than 16 millimeters. And then it has to be dysfunctional. Less dysfunction is needed if you have advanced New York Heart Association functional classes 2, 3, or 4. But if you're essentially asymptomatic, but have a mean gradient across the conduit of greater than 40 millimeters mercury, or you have severe pulmonary regurgitation with RV dilation and dysfunction, then that's also an indication for placement in this trial. They excluded those with active endocarditis, as we do now in clinical practice. We're very, very hesitant about putting these in anybody with even suspected endocarditis or any question of anything active as far as infection, because it's looking like that's going to be another issue, is infections in these valves. Contraindication to MRI was an entry criteria for this trial, but is no longer a problem. You don't need to do an MRI on these patients. You can do all of this in the cath lab now. So it's a humanitarian device. It's authorized by the FDA here for use in pediatric and adult patients, but you have to have conduit that's originally greater than 16 millimeters in size. So here's, when we went to get our training for the valve, they gave us this slide, which is how to assess and decide what to do with the RV to PA conduit. So first you do RVOT angiography. Then you decide, is the narrowest diameter less than or equal to 18 millimeters? If the answer is yes, you have to ask, is the narrowest diameter less than the nominal conduit diameter? And then thereafter you go ahead and pre-dilate with a high pressure balloon, balloon size the conduit, and if the waist on the balloon is greater than 14 millimeters and less than 20 millimeters, then you can go ahead and deploy the Melody. I can tell you that we've been changing these numbers quite a bit. If we find that the balloon diameter is at or less than 22 millimeters, we've been putting the Melody valve in. Because even though the internal diameter of the Melody is 22 millimeters, there's a cuff of bovine jugular vein that gives you an extra 1 to 2 millimeter cushion. So we have been going larger with these. If the answer is no to these questions here, then you just go straight to balloon sizing. And if, frankly, we don't get a waist on a 22 millimeter balloon, or we can't get the conduit to be larger than 14 millimeters on balloon dilation, then that's not an appropriate patient for this kind of technique. And we go ahead and call Drs. Lax or Reamson to take the patient. What were the acute hemodynamic outcomes in these 89 patients that were successfully implanted? The RV to PA gradient, as expected, decreases. The RV pressure goes down. The PA diastolic pressure rises. And the reason the PA diastolic pressure rises is you take away pulmonary regurgitation. So, pretty effective hemodynamically. Not perfect, but very good. What are the potential complications? There's a whole host of potential complications that are device-related and that procedure-related, and these procedure-related complications are complications that many of them you'll see with any a vascular or cardiac intervention. I mean, bleeding requiring transfusion, hematoma requiring repair, arrhythmias, etc. But there are some complications that are specific to the Melody valve. Things like the stent fracture. That's a big issue. The possibility of tearing the pulmonary artery distally when you're trying to do an intervention in the right ventricular outflow tract. Compression of the coronary arteries, and I'll show you an example of that. That's a major problem that's quite specific to interventions in the right ventricular outflow tract, jailing the branched pulmonary arteries. All right, so how do we place the melody? It comes in a plastic cup in a preservative, and then we take it, we rinse it out, and then we actually crimp it onto the balloon loading system. It's called the ensemble system. So it doesn't have a crimper like the Edwards Sapien valve does. And thereafter, it looks like sort of a miniature version of the Qassam 2 rocket. Everybody know what that looks like? No? Oh, interesting. All right, and then we go ahead and sheath the valve, and then this is how the valve is deployed. You have to put a wire, obviously, out into the pulmonary artery. This goes over the wire, it's unsheathed, and then it's a balloon-in-balloon system. You expand the small balloon first, then the larger balloon, and at some point that will expand. There you go. And then the valve is placed. And I wish it was that simple all the time. Here's an example of the valve being placed in a homograft that's stenotic. It's actually not regurgitant because the injection is below the RVOT. There's a lateral view of that. See that there's a ledge of calcium here. And we go ahead and place the valve. This is the balloon-in-balloon system going up in an AP view. And thereafter, there's still a nice waist there where that chunk of calcium is. And this is one of the issues with the homografts, the calcification, the fact that you don't end up getting a nice circular shape to the stent when it goes in. It gets sort of an elliptical shape, so pre-stenting these is sometimes important. But the result here in the end was quite nice, and there's no pulmonary regurgitation, and really the stenosis has been relieved. This is a bioprosthetic valve, which is just a lot easier. You know, it has these markers, it tells you exactly where you need to go. And we'll just, for the sake of time, just look at the lateral views. Here's a high-pressure balloon being expanded within the bioprosthetic valve. At the same time, we're doing an aortogram, looking for coronary compression, which we didn't see. Then we put the melody valve into this nice landing zone provided by the bioprosthetic valve, which has nice struts there for us to hang on to. And this is the final result, or not. Media unavailable. Let's see, I'll show it to you down here then. Oh, there it is. Okay, good. So no pulmonary regurgitation. We've also placed these valves in patients who don't have conduits and don't have bioprosthetic valves. This is a patient who has stenosis of the supraannular region, well above where the pulmonary valve would be. And so what we did with this patient is went through and initially, this is what things looked like. Here's where the annulus would be, but he's had a transannular patch. There's a narrowing here right before the branching of the pulmonary arteries. So there's PS and PR. So we brought him in and we initially put in an uncovered stent in order to build a conduit. And then thereafter, he has now no more stenosis, but he's got severe regurgitation. We let this heal in for a couple of weeks and then brought him back and then landed a melody valve inside of that previously placed stent. And we had a nice result and did not obstruct the branch PAs, and he's done much better. The use of rotational angiography I have found to be extremely useful, and I'm always sort of agitating for it, and we're starting to use it a lot more. This is an example of a dysfunctional homograft. There's stenosis, but there's also wide open regurgitation, as evidenced by all this contrast pouring back into the right ventricle. So you see the stenosis there, and as we turn this sort of live CT image around, we see that we would need to land this valve perfectly to not occlude the RPA. So we also do compression testing with this rotational 3D angiography. I think this is actually what it's most useful for, is looking for coronary compression. And here there's a 25 millimeter balloon that's been inflated in the RVOT, and we're pacing the patient at 180 beats per minute. We're doing the rotational angiogram. It's a 5-second rotation. around the patient, and at the same time we're injecting contrast into the aortic root, and we get a perfect coronary angiogram here showing that the left main is not compressed, even with a 25 millimeter balloon. So we felt good about this, and we went ahead and implanted the pulmonary valve, and it looked good. There's no compression of the branch PA, and you can tell there's really no pulmonary regurgitation. That's just artifact. It's also good for looking for stent fractures. In this case, this is just a MIP of a rotational angiogram showing the stent struts nicely. This is an example of coronary compression. Oh, sorry, this is a little high up here. This is an example of somebody that I think we did this case about 2 weeks ago, patient that was referred from Orange County. And we expanded the balloon and at the same time injected an anomalous left coronary that came off the right coronary cusp. And you can see the compression there of this anomalous coronary by the balloon. So this was not a patient who can undergo a Melody valve placement and should go to surgery. Various types of stent fractures. These are the least serious, just single struts that are fractured. More serious stent fractures are seen here. I didn't include type 3 here, but type 3 is really where the valve is completely fractured and highly dysfunctional. But note, this is the issue here, and this is the problem with homografts. Look at the shape of this stent. And especially if the conduit is right behind the sternum, and then you're getting CPR on that conduit with every heartbeat, and the constant stress on the stent is such that there's a higher risk of them fracturing. This is the argument for pre-stenting. And then I'm just going to end with this here, or almost end with this. This is MRI overlay, 3D overlay, where we essentially crop out the pulmonary arteries and the conduit, RVOT here in the aorta, and we overlay them on the fluoroscopy screen, and thereafter we go ahead and place the Melody valve using fluoroscopy, but really focusing on this 3D overlay. And I think this is the future of some of these interventions and intraprocedural imaging. Our experience at UCLA, when I did this presentation, we've done 64. I think we've now done either 69 or 70 of these. Since October of 2010. We've implanted one valve in the tricuspid position. We've had no mortality. 2 patients had femoral artery dissection that required surgical intervention. 1 patient had infective endocarditis and required that the valve be removed 11 months later. And 3 of these 64 have been hybrid valve placements and have gone well. These are the patients who we need something else for. Patients with a transannular patch. There's nowhere to land this, this valve here. And so this is where RVOT reducers and self-expanding devices will be necessary. Melody tricuspid valve replacement has been done. We've done it. This is a report from Jack last year, 15 patients from multiple centers. It's pretty straightforward if you put it in a bioprosthetic valve, and there is a nice reduction in the gradient if you have tricuspid stenosis and improvement in tricuspid regurgitation. But again, the Achilles heel is the 22 millimeters. So I'll go ahead and end there, and thank you.